Hello and welcome to the Chris Roll Podcast on iCode Media. Today I'm having a great conversation with Dr. Nate Lighthizer, who is one of my colleagues and friends and confidants. And in some ways, he's a mentor to me. I hope that someday I can mentor him as well. And in general, the conversation that we're about to have is related to the practice of optometry, the profession of optometry, how we can help our patients, scope of practice. I know it's going to be a fun one for you. Please enjoy it. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. So today I want to talk about the MyDay multifocal for just a second. It has been a really great thing in our practice for our patients who are presbyopes of all areas, but those tricky presbyopes are always the ones that are kind of emerging, where they don't want to give up any of their faraway vision, but they're having some struggles up close. And so what the MyDay multifocal has been able to do for us is to allow those patients to transition into a multifocal more easily. And then as we have those patients progress into other levels where they need more ad powers, it's been a nice smooth transition. So the ultimate hurdle that we've seen in our practice before the MyDay multifocal was that we'd have patients who would resist any transition to a multifocal lens because of that distance blur. We just haven't seen that. So if you haven't started using MyDay multifocal in your practice, I would encourage you to start, check it out, reach out to your Cooper reps for those trial lenses and commit to MyDay multifocal for your patients. I think they're going to like it. If you haven't checked out MacuHealth yet for your patients in Category 1 through Category 4, I think there's a lot of evidence that you should be considering. The first is, if we just look at AREDS 2 and what they talk about, MacuHealth is, so for patients in Category 3 and Category 4 AMD, MacuHealth is a great option for them that follows that entire protocol, and it also adds mesozeaxanthine to the mix, which, if you look at some of the evidence, I believe shows me that it's going to thicken the macular pigment better than without mesozeaxanthine. It also uses a correct AREDS 2 dose of zinc at 25 milligrams, and so you don't have to worry so much about the potential side effects of zinc. The other thing to think about, and it's beyond the scope of this, although you've probably heard me talk on other podcasts, is that in patients in Category 1 and 2, there may be some additional benefit to supplementing them with something that may be a little bit less than the AREDS 2, so you don't have to add as much to it. And that's where I use the MacuHealth LMZ3. And so I think if you haven't done this yet, I'd consider MacuHealth in your practice and for your patients. And it's been great for my patients, and we really feel like we can have the ability to help those patients in all categories of macular degeneration. So Nate, I wanted to have you on today because I think you're the real deal. I think there's a lot of people that speak all across the country, and maybe this doesn't mean anything, but sometimes you can feel that a guy or a gal, they're sort of faking it. They've got a lot of accolades in the sense of companies like to have them out on different platforms, but they don't have a lot of street cred. And so one of the reasons that I really wanted to kind of highlight you today is because I know you've got the street cred, and you also get the accolades from companies that want your opinion about things, and your opinion really matters to them, and it matters to me. And so one of the things that I have recently been able to see with Nate, and how I know he's the real deal, is that he virtually came to Nebraska to kind of help support some of the things we're doing legislatively. And that really gets to allow you to see who kind of understands their stuff and who really understands the nuances of what we're doing as a profession and how we help patients. And also, because there's no other financial reward in that, who's not a faker when it comes to kind of caring about the profession. So, Nate, thanks for doing that, man. And thanks for doing this.
I appreciate the introduction, Chris. I've looked up to you for a long time. I got to NSU OCO in 2009, so our paths, missed each other by a year or so. And Chris Wolfe is a name that's synonymous with NSU OCO. So you've laid a strong foundation for yourself, and obviously are a tremendous leader for Nebraska, the AOA, and I look up to you a lot as well. So I appreciate the invite, and it was my pleasure to at least try to assist Nebraska as you guys are going through the process of scope expansion. That's It's been a busy last decade in terms of scope expansion, and I think that's a very good thing for patient care. So, which I'm sure we'll discuss in the next upcoming minutes.
So I think that's a good introduction to, because you focus on patient care, and I mean you couldn't look at the 10 states we have now that have pretty significant authority to help patients, and it wouldn't be without the efforts of NSU and specifically you and Rich Castillo, and there's a number of others, Joe Shetler and
Hmm.
Jeff Miller, and I mean we can go down. I'm sure I'm missing people, Michelle Welch,
Yep.
that over the years have really had a big impact. Um, what's the most challenging part when you're educating optometrists to take these next steps, in your opinion? Forget all the politics. What's the most challenging
Mhm.
part for the guy that hasn't done this in a long time to feel comfortable and confident and competent to provide some advanced procedures over time?
I think one of the biggest challenges that we see is just simple busyness and change. We're all very busy. We're entrenched into what we do on a day in and day out basis, a week in and week out basis, whether that's private practice for many doctors, whether it's an OD, MD center, whatever it is. But, adding something new is like, man, do I have the bandwidth to fit that in, to learn a new skill? Let's say I can learn it, but then how do I incorporate it? How do I get the technology, acquisition costs? Do I have the proper patient base? So just the busyness, the change, and I'm doing pretty well right now. Do I really need to add something in? I think that is a challenge that we are overcoming. And I think it's getting easier and easier with technology. It's interesting. I know you know who Randall Thomas is. Melton and Thomas, they're just pioneers in terms of optometric education over the past few decades. And Randall emailed me this morning on, as technology evolves, there's something called direct SLT that's being studied right now. That's transscleral SLT. It typically takes me a minute and a half, 2 minutes, 3 minutes, sometimes 4 minutes, depending on the patient, to do an SLT. And there's a new form of SLT being studied. It's not released yet. That takes 2.3 seconds. And I've shown doctors pictures of this, and it's just their eyes open, going, ooh, maybe I wouldn't do SLT in the current form, but as technology evolves, I think that's going to make them even more amenable to that challenge that we were talking about. So it's just incorporating something new into our busy lives, our busy practices. That's certainly one challenge.
Yeah, I think it's interesting that you make that point, because you and I haven't talked specifically about that ever, but I think that is the biggest challenge as well. Even again, break it down to dry eye or anterior segment disease management when you're going to use an amniotic membrane, or how you're going to do plugs, or how you're going to do a scleral lens, or how you're going to do IPL, or you know, even glaucoma management. The thing that
Hmm.
I'm always really struck by is, and I don't know, I mean, maybe it's different. Maybe I had great mentors in school, and I think after school I had a lot of great mentors as well. But how do you take a patient that comes in with comprehensive, like a managed vision care plan, that's in their mind what they think they need, and then how do you detect the diseases that you need to detect, and then how do you manage that in a way, in a schedule that comports with our clinical practice guidelines, and also allows you to have value for the services you're providing? That actually, for guys like you, has become very simple in your mind, of maybe, I mean, maybe not, but for a very small portion of people, that they get that. They understand this cycle of, okay, I can bring patients in, and if our clinical practice guidelines say for moderate glaucoma, you want to run a field every 6 months on average, depending if things are stable. Once they're stable, maybe you can go every year. But the bottom line is, you could look at our clinical practice guidelines and say, we're going to do this, and this in the course of a year. How do I space that out in a way that makes sense for my practice, so it doesn't bog it down? And then when things come back abnormal, we can order those. Is it okay to order another field? How many fields am I going to be audited if I order too many fields in a year? I mean, these are the things that go through people's minds, and it's almost stifling. They're worried that these things are going to be insurmountable. And I see that as well from my perspective. And I think that's the biggest challenge when integrating any new technology. And yeah, so that's an interesting thing that of all those things, it's not the technical aspects of the surgical procedures that you're
It
training.
it is not. I mean, you and I, very well know, and many doctors out there know, when you're just talking about the technical aspect of, let's say, SLT, and it's one of the most enjoyable things that I see as we go through our laser course and our surgery courses is kind of the light bulb go on, and doctors they always say demystify is the biggest word that was told to me and Rich Castillo as we go through that course, going, I came into this course not knowing if I could or should be able to do this, and it just the light bulb goes on, going, oh, I have most of the skills already to do an SLT or a capsulotomy or a lesion removal, whatever it is. So it's not the technical aspect. Optometry is very well equipped and very well trained to do these procedures that we are discussing. But anytime we step into an element of the unknown, don't we all kind of hesitate a little bit? Most of us do, myself included. It's just, boy, I don't know. I don't know about this. It's going to take energy. It's going to take time. Do I have that energy and time? I'm busy. I'm doing great the way things are right now. Let's just keep it like it is.
Yeah.
So that's one of the challenges that we've discussed.
So convince me. So let's say that I'm a doc out there thinking, we'll just talk about SLT because that's what we're dealing with in Nebraska, and it's kind of front of mind.
Yep.
But there's also a lot of changes that I'm not convinced that most general ODs or MDs, for that matter, have really thought through and embraced. Actually, I can tell you for sure that most OMDs have not really thought through the application of SLT. And when I was being trained, SLT was a close second. I suspect that's how it was when you were doing your residency at NSU. And there's sort of been this flip. And so I want you to talk a little bit about the evidence for that sort of shift over the last 15 years and how we get to this point of having SLT as kind of a primary treatment or, a very close secondary, how you want to go back 1 and 2. So kind of lead us up to the light study in your mind, and then kind of
Yep.
knock the light study out of the park and what that says to you clinically.
Yep. Yeah. So, I did my residency in 2009, 2010 at NSU, and we were doing 180-degree SLTs at the time. And why did we do 180-degree SLTs? Because ALT was done 180 degrees. And because that form of laser trabeculoplasty, that's how it was done. When SLT came about, it was like, well, we probably should start doing it that way as well. And we were typically reserving it until they were on drop number 1, drop number 2, drop number 3. Drops were still fairly solidly entrenched as the first option. And then laser trabeculoplasty was a close second, as you said. Now, again, why was it that way in the late 2000s? Because ALT was clearly a second line option because there was more tissue destruction. It was a photocoagulative laser destroying tissue. So you didn't want to destroy tissue early in the course of the disease if at all possible. And that's why ALT tended to be a second line therapy. And when SLT came about, that's kind of where it started. And then you had the SLT med study that came out in 2012, and that was by Dr. Jay Katz out of Will's Eye. We're all very familiar with Will's Eye.
I'm going to pause you because you're starting to remind me. There's a guy I listen to. His name's Peter McCullough, and he's in Texas, and he is a cardiologist. And he can cite every single paper he's ever written and who wrote that paper. So you just gave me you cited who wrote that paper. So sorry, I got to mention that. That's not a plug one way or the other for his podcast, but you reminded me of, I can't cite authors that well. So keep going and keep citing them. That's so wonderful.
Yeah. So, the SLT med study, and we're all familiar with Will's Eye. And it was really, in my mind, the first big study. There'd been some internationally, but the first big study coming out of the United States that directly compared SLT to prostaglandins for first-line therapy. We all know prostaglandins have been solidly entrenched as first-line therapy. And what was interesting is it did this at 100 shots for the SLT. So we did 360 degrees, went all the way around. And it really was the study that changed our protocol from doing half the eye, 180 degrees, to going all the way around to 360 degrees for most types of glaucoma. Not all types of glaucoma. If they've got significant pigment, we'll still do less degrees, 180 or maybe even less. But it was the study that really convinced us that we need to start doing 360 degrees again in late 2012, 2013. Their conclusion of the SLT med study in September of 2012 was SLT was equivalent to prostaglandins in terms of IOP reduction, and SLT can be used as a safe and effective initial therapy in open angle glaucoma and ocular hypertension. Again, that was a decade ago. Hard to believe that's been 10 years ago. So it just slowly evolved. It takes time to change a mentality. Somebody once told me it takes like a generation to change a way of thinking. And our way of thinking has been drops first, drops second, drops third. Then we consider laser, and then we consider surgery. And really over the last decade with SLT, with minimally invasive glaucoma surgery, MIGS, as you're very well familiar with, it's this mindset of interventional glaucoma, of we don't need to burden the patient with drop one, drop two, drop three. Chris, I bet if it was your eyes, if it was my
Oh,
eyes, I
absolutely.
would
I
want
say
an
it all the time.
SLT first line.
Yeah, I say it all the time, and I even tell my
And and
patients.
ma-
I tell my patients that look, we have these two options. This is how I would want it managed, and this is and you can pick which one you want to start with if you have a strong preference. And the very first question, and you know exactly what I'm going to say. The very first question is,
Mhm.
well, can you do that? And
What would you do?
which I
Yeah.
can't. And when I say no, I'm going to send
Yep.
you over to Dr. So and so, and they take great care of you. I think I'll just start with the drops and see how that goes. However, when I had that exact same conversation in Oklahoma, when we said yes, we can do it in this clinic, they would opt more likely than not to opt for SLT first or very close second than adding a second medication. So anyway, sorry, keep going. But I see that all the time.
No, all the time. They ask, okay, we have two great first. It's exactly how I phrase it to patients. We have got two great first line options. We've got eye drops that work well. We've got this laser therapy called an SLT, works great, very gentle to the tissue. And they often ask, well, doc, what would you do? They don't always ask, but they often ask, what if it was your eye, doc, what would you do? And I tell them I would have an SLT. And then it's pretty easy for me to then walk them across the hall in Oklahoma and do it myself. I was lecturing somewhere a number of years ago, and I think it was I can't remember, somewhere on the East Coast. And a doctor raised his hand and said, Nate, I hear all what you're saying. This is great stuff. It's pretty easy for you to recommend SLT when you can walk them across the hall. I'm in private practice, can't do the procedure in my state. It's not allowed. I've got to refer them out. They may not get the procedure I ask. The patient may not come back to me because of that. There are certainly issues that they have to deal with. And he was absolutely correct. So, those are issues that docs in other states that can perform SLT have to deal with. And that's why I told you in our hearing a couple weeks ago, I believe it would be a huge public health win if optometrists had the scope of practice to allow SLT. It would decrease the burden on many patients.
Yeah,
Anyway,
absolutely.
fast forwarding after the SLT med study, there was just a slow inching forward 2012 to 15, 16, 17. And then you get to the Light study released in March of 2019 by Gus Gazard as the lead author. And it really was a shove forward going. Their ultimate conclusion is SLT not could be, should be offered as first line therapy, supporting a change in clinical practice. I mean, that is some big words there. Should be offered, supporting a change in clinical practice. Basically telling clinicians.
Years, before you get to that, we haven't seen in the last 3 years anybody really dispute that.
I haven't seen anybody dispute that. I mean, it has basically been, yep. Because again, when you ask doctors, what would you do for your eyes? Most doctors, the ones that know what's going on and understand all the options, I've asked that question hundreds of times, Chris, and I will tell you, it's always between 85 and 95% of eye doctors said if it was my eye first line, I'd want an SLT.
One of
so
the things
it really,
that I'm seeing is, I think we've been in practice now long enough, and I have enough patients that have aged and with me and have been on glaucoma treatments for long enough. And I'll tell you, while I still use prostaglandins as a first line treatment when patients don't want to have an SLT, and they're super effective. I mean, I'm seeing more and more patients with kind of just these chronic red eyes, worse dryness, worse MGD. And when we can get them off, like when I can finally convince a patient to use it, to get an SLT, and they've been on even just 3 or 4 years of a prostaglandin. And that's not to say they're bad medications, just that, they come back. I had one just the other day, come back, finally convinced her to get an SLT. we've been able to pull that prostaglandin away. And I haven't seen her eyes look this good, just white and quiet. And I mean, in a year, probably a year, I haven't seen her and symptoms under control. I mean, ocular surface looks wonderful. So it's just something that's kind of ringing true. I'm seeing more and more of that over time. And that's even just more compelling to me to continue to make the case for, for those patients early on.
Yeah, I mean, how many of our patients battle compliance, battle cost issues? We all know we deal with that. And that's not even mentioning what you just said of how many of your glaucoma patients also have ocular surface disease, have MGD, and our glaucoma medications, our eye drops are helping to lower the pressure. They're helping the glaucoma, but are they exacerbating or worsening, other conditions? I think that happens quite a bit. So, and then finishing with the light study, from 2019, it really helped to answer the criticisms of the SLT med study, which is that the SLT med study in 2012 didn't have huge N numbers, and it was only a 1-year study versus the light study had huge N numbers. There was 320 plus patients that went down the SLT arm and that went down the prostaglandin arm. So huge N numbers in each arm. And it was a 3-year study, multi-center. And that's why the conclusions were very, very strong when it came to the light study. And again, 2019, and it really was just a shove forward going, we now have 2 first-line options. We've got drops, we've got laser. I'm not saying one is better than the other, but that's how I present it to patients. We've got 2 great first-lines options. And I actually quote a stat from the light study that, and I tell patients this, when we talk about the pros and cons of eye drops and the pros and cons of SLT, I tell them that there is a 75 to 80% chance, if we choose the SLT, that we can keep you drop free for the next 3 years. So 75 to 80% chance. The downside with this laser is it's not going to last forever. We're probably going to get somewhere between 2 years and 6 years, somewhere in there. Sometimes it's a little shorter. Sometimes it can be longer. The bulk of the time, it's right in the middle. So sometimes it can be shorter, sometimes it can be longer, but 2 to 6 years. The downside is it doesn't last forever, but here's the really good news. You can do it again. And we do it here right in the office. It just takes a matter of minutes. So that's what I tell patients. You got a 75 to 80% chance to keep you drop free for the next 3 years. We likely will need to do this again, but that's okay. We can do it again. It's very repeatable.
Yeah, I think that's it. I mean, it's so compelling to me. It's so compelling to me that I actually think at this point in time, and that's why, it's kind of what we're focused on in Nebraska. But at this point in time, I have my opinions. So I've already kind of disclosed those. If you think about laser procedures, capsulotomies, peripheral iridotomies, the common ones that we would think about, and selective laser trabeculoplasty, in your mind, across the country, which one do you think people automatically think about first when they think about laser procedures from an OD perspective of what they want to change? But which one? So that's the first question. The second question is, which one do you think is most impactful to our patients?
Yeah, so this is a clear answer to me. I think doctors think the first one is going to be YAG capsulotomy. I think that's I don't know if flashy is the right word, of that, but it's probably the number one. It's not probably, it is the most commonly performed laser procedure by optometrists in the 10 states that have lasers. It's number one. And it's what doctors think about because they remember that patient that had PCO with decreased vision. And you do the procedure and the patient's thrilled. And it's a very, very rewarding procedure to do, and optometry is well qualified. So I think that's the one that pops to the mind first. I feel very strongly that the one that would have the greatest impact is SLT because of everything that we have talked about. I mean, and I still see, and I believe that SLT is underutilized by optometry in the states that have it, in Oklahoma included. There's a lot of doctors doing YAG caps. And they're not doing SLTs. And it's, again, I think it goes back to that it takes some time to have a change of mindset. We've been trained for decades on drops for glaucoma. So I think it's underutilized. So YAG cap is the one that comes to the mind the first, but SLT to me would have the greatest impact.
I'm gonna round this out. with our last hearing that you were participating in, there was a woman that they brought out, and you can never know. I mean, I made this comment during the hearing, is that it's very hard to know exactly what happens in an exam room and exactly what a patient prefers, etc. But they brought out in her testimony was that she had been placed on 4 medications, and she was seeing a glaucoma specialist who happened to be an optometrist, but she didn't know that they were an optometrist. She thought they were, for some reason, she thought they were her claim was that thought they were a medical doctor. Again, the idea. So, and then she was rushed. She saw a glaucoma specialist ophthalmologist, and she was rushed into having what sounded like trabeculoplasty. And, when you think about the legislature and you think about, or in our case, a review committee who, is not in the legislature, consists of a lot of lay people. The nuances of glaucoma management are really challenging to articulate. I mean, the fact that you can first of all, the fact that optometrists can absolutely be glaucoma specialists, and this idea that because they were an optometrist, they weren't a glaucoma specialist, I mean, is just baffling to me. But how do you articulate that well to a layperson? They don't have any idea, and the nuances of articulating that are challenging. And the fact that the idea that most general ophthalmologists don't really like glaucoma that much. They want to do cataract surgery. They want to do LASIK. They'll treat glaucoma with some medications, just like most medical minded optometrists, and they'll do maybe some SLTs here and there, or they'll refer, out for trabs. But most of them aren't doing trabs. Most general ophthalmologists aren't doing trabs unless they're in a small community.
And I think they underutilize SLT
Agreed.
just like optometry does. I think glaucoma specialists utilize it, and maybe they underutilize it. But general ophthalmologists, I agree with what you said. Cataract surgery, LASIK, they'll treat glaucoma. But if they want surgical glaucoma, they're usually sending to a ophthalmology glaucoma trained specialist.
And so that patient, what's really hard is that even if that patient had seen another glaucoma specialist, ophthalmology glaucoma specialist, they might not have rushed her into surgery, rushed her in for a trabeculoplasty because they couldn't wait for her pressure to be lower from an SLT. And I would assume that all of that might be normal. They might have rushed her into cataract surgery with a MIGS. Would that make the glaucoma surgeon that rushed her in for a trab wrong? Would that make him wrong? There's the nuances of even just glaucoma. I mean, this idea that you can stick 100 glaucoma specialists, optometrists, and ophthalmologists in a room and present them one case and say, what do you do? And there's going to be optometrists, ophthalmologists on both sides, and some of them will say this and some of them will say that, and that's the challenge with glaucoma. It's the fun part, and it's also the patient, the part that every single one of them could be entirely wrong in that specific patient scenario because they didn't actually sit down and have a conversation with the patient and know what their wants and desires and needs are, and that refines how you approach that patient. And so it's just a really hard thing to articulate. What are your thoughts about that, and how could we have done that better for the presentation that was made a few weeks back? Any insights?
Glaucoma is such a gray area, as I call it. The nuances, as you called it, black and white. There's a little bit of black over here and a little bit of white over here, and a tremendous amount of gray in the middle. Just like you said, you can't you present a glaucoma case to 5 optometrists and 5 ophthalmologists, and they give their answer so the other ones can't hear. And there's going to be so many different ways that you can manage glaucoma, and none are more right or wrong than the other ones. It's just different. Now, there's always a, kind of a pedestal that ophthalmology is put here and optometry. And it's unfortunate for optometry because we will always be questioned and we will be always second guessed when I do something this way and an ophthalmologist does it a different way, just because of the nature of, kind of the tiers or silos we're put in. We will always be questioned as an optometrist. So I think it's unfortunate in these hearings going, okay, here's one particular case that may or may not have been managed differently, may or may not have have not went the way we want. But that's everybody makes decisions in an exam room based on the information that you're given, and we all do things a little bit differently. And those nuances, to me, really should prevent us from questioning another doctor and what this management they did, because there's just so many different roads that you can go down and so many different ways that glaucoma can be managed.
I think it leads to the idea of, there's bad care and then there's poor outcomes. When optometry in these hearings, when something goes bad or doesn't go perfectly in an optometrist's hands, it's bad care. That's how ophthalmology wants to make it sound. When it goes bad in an ophthalmologist's hands, it's just a poor outcome. It's just a foreseen complication. And it's a battle we have to fight.
Things happen, right, Chris? They just happen.
That's right. But so here's what I want to do. I'm gonna ask you online so people can hear you say yes. But I want to talk to you about a number of other things related to other surgical procedures and kind of your experience across the country. But I want to do that in pieces. So I'm going to probably reach out to you again multiple times if you'd be open to it, because I think there's this whole story that we can tell over time that will be much more interesting than if we tell it all at once. So I'm going to ask you to come back, and we'll have you back for other topics. Would you be interested in that?
Absolutely, yes. The answer is yes.
Awesome. Well, I'm going to be respectful of your time. Dr. Nate Lighthizer, you're the man. Thanks for doing everything you do. Thanks for coming on. I appreciate it.
Appreciate it, Chris, very much. I appreciate the invite. Always enjoy chatting with you, and I look forward to next time.